Alors bonjour, merci d'être si nombreuses et nombreux en présentiel et en virtuel également ce matin pour ce premier panel de la conférence Lalonde 50 ans, comment pouvons-nous faire avancer la promotion de la santé équitable? Alors je suis Stéphan Gervais, je suis coordonnateur scientifique au programme d'études sur le Québec à l'Université McGill et également au Centre de recherche interdisciplinaire en études montréalaises à la même université, à la Faculté des Arts. I would like to thank the leadership of the Department of Equity, Ethics, and Policy of the McGill School of Population and Global Health for organizing, with the help of other partners, of course, this stimulating conference on such an important report. 50 ans après sa publication, le rapport Lalonde, qu'on peut certes qualifier de visionnaire, continue d'influencer les politiques de santé publique, et c'est ce qu'on va notamment entendre ce matin. Ce premier panel va justement se pencher au contexte historique plus large de la promotion de la santé, des catégories médicales et de la politique de l'assurance canadienne. So, it is a very broad topic, but you can be thankful we have wonderful experts on the panel this morning. Alors, to tackle this historical perspective and context, it is a great privilege for me to introduce to you our three distinguished guest speakers. En effet, nous pourrons miser sur les analyses éclairantes de trois distingués invités. La première personne est Professor George Weisz, the Cotton Anna Chair of the History of Medicine at McGill University in Montreal. La deuxième personne est Professor Catherine Carstairs, a Professor History at the University of Guelph. And the third person is Professor Gregory P. Marchildon, Professor Emeritus at the University of Toronto and the founding director of the North American Observatory on Health Systems and Policies. Alors, la première personne qui va prendre la parole ce matin, je vais donc le présenter. C'est un honneur pour moi de présenter le professeur George Weisz. Our first speaker is Professor George Weisz, who is Professor in Social Studies of Medicine at McGill University, and as I was saying, the Cotton Anna Chair of the History of Medicine at McGill University in Montreal, of course. His most recent monographs are Chronic Disease in the 20th Century, a History, and Divide and Conquer, a comparative history of medical specialization from 1830 to 1950. That was published in 2006. He has also written books about the creation of French universities during the Third Republic and the history of the Paris Academy of Medicine in the 19th century, and as well editing 5 collections of volumes. So, we will start with the presentation of George Weisz, and his presentation today is Chronic Disease, Social Medicine, and the Lalonde Report. Professor Weisz.
Thank you very much. There were many influences that led to the Lalonde Report, relatively new health insurance systems, and the need to maintain cost control, an apparent lack of health improvement relative to money spent, general unhappiness with expensive biotechnological medicine reflected in the WHO's Alma Ata declaration, and even more dramatically, Ivan Illich's general condemnation of medicine. And my colleagues on this panel are going to deal with many of these issues, including the federal, provincial politics here in Canada. But today I want to talk about some of the intellectual influences that lay behind this report. Looking over the report for the first time, I must say, in 40 years, it was actually a very interesting thing to do. I noticed two things. This is not working. Oh, sorry. So I have to do this?
No, it should work now.
Oh, I see, okay. The first thing that is fairly obvious is that this is clearly not an academic paper. There are only 10 references, and no less than 3 of them are by Thomas McEwen. McEwen was a professor of social medicine in the UK, in Birmingham. There's a very strong Canadian connection, by the way. He received a BA from UBC and a PhD from McGill. My colleague Don Bates invited him to give the 1979 Osler Lecture here at McGill, where a lot of people showed up to hear him speak. And in fact, this is well-known stuff. Hubert Laframboise, who is probably the chief author of the report, says in a paper he wrote almost 20 years later that he came across, or he was given M's work in 1972, and it had a tremendous influence on him. The second thing that I found rather striking is the words chronic and chronically, which appear very, very frequently in this manuscript. And what I'd like to do today is kind of talk about the relationship between McEwen and this emphasis on chronic diseases. So McEwen's early work looked at historical statistics, and his first task was to demonstrate that the rise of population since the 18th century was not due to higher birth rates, but was due rather to declining mortality. And a major contribution to this declining mortality was tuberculosis, whose decline began long before any effective medical interventions, as this chart points out. 2 years after the Lalonde Report, McEwen published a kind of synthesis, a comprehensive synthesis of possibly 15 years of research, where he argued that mortality decline was due to more and better food, improved living conditions, and he was willing to admit, probably with some resistance, public health measures as well, but very definitely not due to improved medical care or biomedical therapies. And this, of course, created a major, it's probably the only major debate that I know of in the history of medicine that has, and not just the history of medicine, but public health. It was a huge controversy at the time. Now, he did this not just with tuberculosis. He showed that except for polio, the book is full of charts like this that seem to show that medicine had little effect on declining mortality. And this seems to be the main lesson that Laframboise took from McEwen's work. But there is something more if you look more closely. If you look at these declines, the implication, which is developed in his more programmatic suggestions in the second half of the book, is that the main problem is that infectious diseases have largely been replaced by non-communicable diseases or chronic diseases. And that's pretty clear near the end of the book. Now, the claim had been in circulation in the United States for well over 50 years by now. And by the 1970s, the idea that non-communicable diseases had replaced infectious diseases had been codified around a term coined by Abdul Omran, the epidemiologic transition, which kind of became a shorthand for epidemiological changes. It meant that writers didn't have to cite a whole bunch of epidemiological studies. They could just point to this, and it became a kind of a shorthand, as many citations, or as some citations actually do. But the reality is that there was always doubt about this kind of reasoning. In the 1930s, 40s, and 50s, American statisticians like Louis Dublin, in the UK, W.P.D. Logan, questioned such claims. They found that they were highly exaggerated. More recently, the coexistence of NCDs and infectious diseases have become clear and have led to numerous revisions of the theory, 4, 5, 6 stages. A lot of stages have been introduced. And even more recently, the distinction between communicable and non-communicable diseases has been criticized for not making any sense when we've learned that so many chronic diseases, in fact, are linked to infections, and social factors like diet, like smoking, can actually be thought of as communicable, as kind of network events. My own judgment on these debates is that there is certainly a case to be made that the proportion of chronic non-communicable diseases almost certainly grew as infectious diseases declined. There may even have been an increase in incidence, but it's really important that doesn't to explain why it created, I won't say the word, I shouldn't say hysteria, but it created at a time when mortality rates were going down globally. It nonetheless created a great deal of concern, particularly in the United States. And so in order to understand that, you have to also look at the political and cultural reasons that made the apparent rise of chronic diseases so disturbing to so many people. And the third point, which I constantly repeat when I speak to medical students, when I give lectures to medical students, is for the last 50 years, we have been actively looking for chronic diseases. And when you look, you find. When you look, you find, and we find many more cases of traditional diseases, and just as important, we're constantly creating new ones like moderately high blood pressure and high cholesterol. So one of the arguments in a book that I wrote about a decade ago is that for the first 2/3 of the 20th century, the chronic disease problem was largely an American problem. It's not that in the UK and France we're not concerned with cancer or with heart disease, or in the UK, rheumatoid arthritis, but they didn't turn it into a major campaign that needed to be resolved immediately or quickly. And the American movement, I can only describe it as a movement, had many streams. In the first place, there was welfare issues. More and more welfare recipients could be found in rapidly growing urban cities, particularly like New York City or Boston. For the most part, they were not treated in hospitals, even if they were admitted to the hospitals, and they certainly weren't treated when they were warehoused in places like almshouses or even asylums. And as urban populations grew, this became more and more of a problem. And New York City was the center of a lot of this activity. At the same time, the public health world was, at least elements of it, were beginning to think, well, maybe in addition to infectious diseases, we should expand our interests and our scope to chronic diseases. Charles Winslow, probably the leading public health figure in the United States in the 30s, 40s, and 50s, was one of the first to make this argument. In the 20s and 30s, there was a movement to incorporate prevention into clinical medicine through such techniques as periodic physical examinations, and that brought together sections of the medical world, public health, and not incidentally, the insurance, the insurance industry. And since there was relatively little that medicine could actually do during this period, the emphasis was on proper care for those who could not be cured and could not take care of themselves, and from the very beginning, a focus on prevention through behavior change, from the very, very beginning. It led to such things as campaigns for annual health examinations or the Life Extension Institute that did tens of thousands of physical examinations, mainly for the clients of insurance companies. It led to the building of chronic disease hospitals. Probably the biggest one was built on Welfare Island in the East River, the Goldwater Hospital. It was huge. It had nearly 1,000 beds. It had a very strong research mission. And in 1950, a second chronic disease hospital was created on the island. Soon after, the idea of having segregated chronic disease hospitals was rejected in favor of integrating chronic disease wards into general hospitals to make them part of general medicine. One of the reasons that chronic disease became a national issue was the movement for national health insurance in the United States that persisted throughout the first half of the 19th century. The problem was that mortality rates were going down. So it was hard to create a sense of crisis or even need for national health insurance. And the solution was to focus on chronic conditions whose incidence did seem to be going up and which could be manipulated statistically. In 1933, the New Deal brought many of the medical reform figures from New York City to Washington, and a decision was made to undertake an unprecedentedly large morbidity survey of chronic disease. And the results began to appear in 1938. They made the front page of almost every major newspaper and were a direct copy of an essay that came from the Public Health Service. And the results were extremely striking. 6 million people found ill in one day by a survey. Now, they got this figure by doing, a little bit of a, how should I put it? A little bit, by twisting the data slightly. They defined chronic illness as 7 days or more of disability or inability to work. Something, by the way, that the American Medical Association picked up immediately. Nonetheless, it was very, very striking, and it had a lot of influence. It was followed almost immediately by a National Health Forum, a meeting to discuss national health insurance. The final report had a section on chronic disease, was written by the same person who had done the chronic disease survey. But of course, the legislative effort to introduce national insurance failed. Chronic disease was also on the agenda of another National Health Assembly in 1948 that preceded the Truman administration's effort to introduce national health insurance, and that which also failed. So the chronic disease, concern with chronic disease took on other characteristics. One of the main ones, and people don't really realize it, but if you look at the announcements for the massive expansion of the NIH, of the National Institutes of Health, after the Second World War, the constant theme is that this is about chronic diseases. This is about dealing with chronic diseases, and virtually all of the initial institutes focused on chronic disease. In 1949, with the government apparently out of the health reform framework, major medical associations created the Commission on Chronic Illness, which published 4 volumes of reports. In the absence, I've argued that in the absence of national health insurance or clear-cut governmental guidance, chronic disease became a way for these medical associations to think about reorganizing healthcare in the US. In the 1960s, of course, the US introduced Medicare and Medicaid, which in fact did cover 2 groups that were recognized to be particularly susceptible to chronic diseases, the elderly and the poor, which is really the first American governmental intervention into this area. Now, all this, I'm sure, was certainly known in Canada, but that's not what the Lalonde Report focuses on. And I think the reason is that while Americans were advocating for behavior change, they did not question the centrality of biomedicine. In fact, if you look at the history of the NIH, the budget of the NIH multiplied by 500% during the 1970s. Americans have always believed, whatever their other beliefs and their other concerns, that biomedicine and biomedical research is critically important. McEwen, of course, didn't. And as a result, it was much more conducive to the points that the Lalonde Report was trying to make. Now, McEwen was part of the British social medicine tradition. It is a tradition that one hears about a great deal, but it's rather difficult to define. Dorothy Porter has made this point. She is perhaps the leading historian of social medicine in the world these days. But she says that it was really based on a number of fairly general, vague ideas. Medicine should be a vehicle for social reform and equity. There should be concern with social determinants of health and illness, and there should be universal access to health care. And in fact, a system of chairs of medicine of social medicine chairs were set up in the UK, and McEwen was one of the first professors appointed in 1945. Porter goes on to say that social medicine basically split during the post-war years. In Latin America, it took a much more radical turn towards societal reform. In the UK, it began to move towards behavioral risk factors that influenced all disease, but chronic diseases especially. So another one of the original professors of social medicine wrote in 1949, so let me step back a little bit. Social medicine was one vehicle in the UK for emerging concern with chronic disease. Another of the original professors of social medicine, John Ryle, argued in 1949 that social medicine and public health needed to pay greater attention to different chronic diseases, which could be correlated with one of social medicine's, or with two of social medicine's major concerns, social and occupational conditions. A key figure in this was it was Gerry Morris, who became the first head of the social medicine research unit at the Medical Research Council in the UK. And Morris did the first major study of the role of physical exercise on coronary heart disease by following occupations that did and did not involve physical activity, showing that physical activity made a very significant difference in morbidity and mortality. Morris, by the way, had immense influence among epidemiologists and health service researchers, not just in Britain, but in the United States. One of the leading health service researchers in the United States has said that Gerry Morris is responsible for health service research. By the 1950s, behaviors were being studied internationally as disease causes, particularly in the case of smoking and in the case of cardiovascular disease. And here the Framingham heart study is usually cited as a major stimulus to the study of behaviors and chronic diseases. So, what were McEwen's conclusions? He incorporated much of this, and it was not original to McEwen, but he added his own tilt. While better living standards were the key to health improvements in the past, now personal behavior had become the most important element, the most important solution for disease. Now, here, he is no longer being very original. He is transmitting what has become a very popular theme of chronic disease epidemiology and public health internationally. So, the Lalonde Report directly cites McEwen's historical analysis and then looks at the major causes of death. It provides Canadian data that demonstrates the role of lifestyle. By the way, much like the US survey of 1935, which defined chronic disease as 7 days of inability to work, the data is somewhat skewed because it measures years of life lost relative to age 70, which gives exceptional weight to the death of younger people. What the Lalonde Report adds that is new is a framework for thinking about health in which lifestyle, at least rhetorically, is equal or analytically is equal to biology and the environment in understanding disease. But there's a second, less discussed element in McEwen's vision that stems directly from his belief that the focus on biomedicine is no longer the best strategy for dealing with diseases. And that goes back to his early history as a young professor of social medicine in Birmingham. In the 1950s, he was doing local hospital surveys, as many hospital physicians were, because the hospital system was being rebuilt, completely rebuilt in the UK. And the goal of many of these surveys was to try to rationalize services, so that everybody, every kind of problem got the goal, that the treatment that it needed. And one of the things that these surveys showed, that despite the building of new hospitals, many of the sick elderly had been left behind in old, poor law hospitals without proper facilities for care. So the question was how to provide adequate care for these people who are not getting it. And this is very similar to what reformers in New York City had tried to do in the 1920s and 30s. And things even got worse in 1957 when it was decided to limit the number of beds for chronic patients in hospitals, which increased bed shortages. So McEwen wanted to bring all the groups excluded from hospitals, excluded from proper health care, into mainstream medicine. And in 1958, he published his ideas for a comprehensive or balanced hospital community to bring excluded groups like the elderly, psychiatric patients, mentally disabled, bring them into the hospital, which among other things would force doctors to deal with these groups because doctors did not really like to deal with these kinds of patients who did not get better. And one of his major points is that the reason they had been ignored was because of the focus, the excessive focus on sophisticated biomedical innovations. So in a part of the book that's rarely discussed, he refers back to his Balanced Hospital Community paper and argues that acute care does not meet the needs of the majority of hospital patients. It does not solve underlying problems. And in fact, acute crises can be avoided with proper care throughout long-term illness. And one finds similar ideas in the Lalonde Report. McEwen is not mentioned here. And in fact, Lalonde in a speech briefly mentioned a series of provincial reports that stressed the need to shift away from costly acute care to less expensive kinds of care and health maintenance. But whatever the source, it's not clear to me just how committed the authors of the Lalonde Report were to this point. It's offered near the end of the report in just 2 pages. I've seen very few references to this in subsequent speeches by Lalonde and Laframboise. It's clearly not the take-home message that people got from this report. So to conclude, there can be no doubt that health promotion has been pursued vigorously and has become central to healthcare in North America, although not as central as its advocates would necessarily like. But it's central enough to have produced a lively critique and counter-reaction that considers it victim-blaming and has led to, again, at least rhetorically, a greater concern with environmental factors in addition to behavioral factors. But it's hardly clear that there has been an equivalent effort to raise the level of care in North America or elsewhere to the level of cure as McEwen had suggested. Certainly many hospitals and hospital beds were closed down subsequently, but COVID, I think, has vividly demonstrated the continuing weaknesses of long-term care in much of Canada. Thank you.
Well, thank you so much. Thank you to Professor Weisz for this wonderful, stimulated, comparative, in-depth presentation that really ends with a with a very important question on care and cure. So thank you so much. Our second speaker is Professor Catherine Carstairs. Catherine Carstairs is Professor of History at the University of Guelph. Her most recent books are The Smile Gap, Oral Health and Social Inequity, and also Be Wise, Be Healthy, A Morality and Citizenship in Canada and Canadian Public Health Campaigns. She's currently starting a project on the history of alcohol use and public health recommendations around alcohol in the late 20th century. And I believe that her presentation title today is Insidious Habits, the Moral Vision of the Lalonde Report in Historical Perspective. Looking forward to hear you. Catherine?
So I think we're going to see a lot of that graphic today. The Lalonde Report has been celebrated as an important Canadian contribution. Sorry, just making sure my slides work here. The Lalonde Report has been celebrated as an important Canadian contribution to the development of health promotion. And to some degree, it's also been described as important in sort of developing the social determinants of health. My paper will argue that the Lalonde Report certainly did make a strong case for health promotion, but it paid relatively little attention to what we would now call the social determinants of health. Written at the time when the federal government was getting quite concerned about the growing cost of Medicare, it introduced the health field concept, the idea that health was more than health care. It was about human biology, healthcare systems, the environment, and lifestyle. The focus of the report was very much on lifestyle, and it drew on a long tradition within public health in Canada of blaming individuals for their own health problems. It paid very little attention to the systemic barriers that prevented people from eating well or exercising, or the pleasures that existed in smoking and drinking, especially for people trying to escape grinding poverty, alienating working conditions, or childhood trauma. This paper will contextualize the Lalonde Report in the longer history of public health campaigns in Canada, showing the links between this report and previous efforts to encourage Canadians to eat healthily, drink less, and exercise more. At the end of my talk, I will also talk about the intellectual origins of the social determinants of health and argue that our current understanding of the social determinants has little to do with the Lalonde Report. So it's a bit more negative than some of the stuff we've heard so far. The Lalonde Report begins by celebrating Canada's healthcare system, especially the prepaid access to medical and hospital services. But it warned there are looming threats to health, including environmental pollution, city living, habits of indolence, the abuse of alcohol, tobacco, and drugs, and eating patterns which put the pleasing of the senses above the needs of the human body. The report divided deaths in Canada into two categories: those that occurred before 70 years of age, which was slightly less than half in Canada at this time, and those that occurred after the age of 70. And the focus of the report was really on these early deaths before the age of 70. And this, I think, is actually one of the most interesting things about reading the Lalonde Report now, right? As I think about my 90-year-old father, every time someone his age dies, it's that they died so early. We really have, our expectation of life has changed since the Lalonde Report was published. Now, a significant portion of these early deaths, around 10%, occurred in children under the age of 5. It mentioned that the economically deprived segments of the population, including Indigenous peoples, quote, contribute disproportionately to the infant mortality rate in Canada. But this is not attributed to racism, the trauma of colonialism, the lack of access to medical care in reserved communities, or the systemic effects of poverty and unemployment on mental and physical health. Instead, the report blamed the less privileged for not recognizing the importance of early prenatal care. It claimed that universal prepaid health care had practically eliminated any financial barrier to accessing this care without recognizing that significant barriers remained, especially in rural communities and particularly for people living in isolated reserve communities. Nor does it mention lack of transportation, the inability to take time away from paid or household work, or mistrust of medical authorities, which we know was already a significant issue amongst Indigenous peoples at this time. The report acknowledged that economic circumstances and physical access to healthcare are important, but the bulk of this section on early deaths amongst the youngest Canadians places high blame for infant mortality on the economically deprived themselves. And yet, medical authorities, as Mary Jane Logan McCallum has written about, had long recognized the devastating impact of colonialism. They didn't necessarily frame it that way, but they certainly recognized that the arrival of settlers had had a devastating effect on Indigenous health, and it was well known that health services in northern communities were inadequate and substandard. For people between the ages of 5 and 35, the leading cause of death was motor vehicle accidents. The second was generalized accidents, and the third was suicide. Failing to recognize the role of transportation system design and the inadequate attention paid to safety by car manufacturers, which Ralph Nader had drawn attention to in his book, Unsafe at Any Speed, which had been published actually 8 years before the Lalonde Report. The report pronounced that these deaths are, quote, mainly due to human factors, including carelessness, impaired driving, despair, and self-imposed risks. After 40, cardiovascular disease was the most significant factor in these early deaths. This was blamed on obesity, smoking, stress, lack of exercise, and high-fat diets. The second most important cause in death in men amongst the ages of 40 and 70 was cancer and other diseases attributed to cigarette smoking. In this section, the report does mention the environment as a potential cause, but the report is far more precise and detailed about the self-imposed risks than it is about environmental factors, which further leads to the victim blaming aspect of this report. And I'm drawing, a lot of my slide images come from sort of advertisements from the time period that, were encouraging all of these poor habits. The rest of this chapter talked about self-imposed risks and environmental risks. The self-imposed risks included drug and alcohol consumption, diet and exercise, including, interesting, malnutrition as a self-imposed health risk. And others, including promiscuity and lack of seatbelt use. The much shorter section on environmental risks mentioned air and water pollution, urbanization, and a brief mention of working conditions and poverty. The report took a negative view of, quote, rapid social change on the mental and physical health of Canadians, and concluded that, quote, when a society increasingly pursues private pleasure by sacrificing its obligations to the common good, it invites stresses whose effect on health can be disastrous. So the Lalonde Report indicated that there were 9 hypotheses on which there was enough evidence to act now. And these were, it is better to be slim than fat. The excessive use of medication is to be avoided. It is better not to smoke cigarettes. Exercise and fitness are better than sedentary living and lack of fitness. Alcohol is a danger to health, especially when driving a car. Mood-modifying drugs are a danger to health unless controlled by a physician. Tranquility is better than excess stress. The less polluted the air is, the healthier it is, and the less polluted the water is, the healthier it is. So it's important to note here that 7 of these are in the realm of lifestyle, and only 2 of them really fit under that environmental framework. So the report emphasized that the health field concept was designed to provide a way of thinking through the causes of health and illness and to help identify what actions could be taken to improve health. Here, again, the report mentions traffic accidents, underlining that the primary cause was risks taken by individuals, with lesser importance given to the design of car and roads and the availability of emergency treatment. So in short, a close reading of the report shows that it had really very little to do with health equity. Instead, as Irwin and Scally argued in a 2007 article in Global and Public Health, it is more accurately seen as a, quote, neoliberal contribution, which framed, quote, the non-medical influences of health in terms of individual lifestyle choices. Now, I'm certainly not alone in pointing out the victim-blaming aspects of the Lalonde Report. Lalonde himself mentioned this in his 2002 acceptance speech upon being selected as one of the heroines of the 20th century in the field of public health by the Pan American Health Organization. And he pointed out that many people at the time the report was released had rebuked it for paying too little attention to the economic and social policy issues behind health. And as many scholars have pointed out, the Lalonde Report provided a justification for reduced spending on healthcare. Now, holding individuals to account for their own health problems has a long history in Canadian public health. As we showed in our book, Be Wise, Be Healthy, Morality and Citizenship in Canadian Public Health Campaigns, which I published with 2 of my former graduate students, Bethany Philpott and Sarah Wilmshurst. The primary pillars of the Lalonde Report, that people should eat better, exercise more, and drink less, certainly had a long history in Canadian public health. And particularly through the organization that we study, which was called the Health League of Canada. So the Health League of Canada was born just after World War I, and it existed. It actually still formally exists today, but really sort of ran out of steam in the 1970s. In its heyday, they published a magazine called Health, which came out from 1933 to 1981. And although it had a relatively small subscription, was widely available in doctors and dental offices, so you could sort of peruse through it as you were waiting for your appointment. The Health League also carried out massive campaigns on a yearly basis, which included National Immunization Week and National Health Week. The group actually started its life as the Canadian Social Hygiene Council, and it began as an anti-venereal disease, as it referred to itself at the time, group, and then it moved into vaccination, industrial health, nutrition, and water fluoridation. In all of the Health League's campaigns, the focus was really on the individual citizen to make the right decisions around their health. Whether this was to vaccinate their children, vote for water fluoridation, or avoid what the Health League would describe as promiscuous sexual activity. Well, the Health League was a private organization. It did receive grants from the Federal Department of Health and then Health and Welfare Canada, and was impressively well networked in Canadian health, government, and business circles. And so they had a broad support, and they had their materials appear in the Royal Bank newsletter and things like that. So it had an influence that really punched above its weight. So these pillars of the Lalonde Report and their history. So the first one I'm going to talk about is eating better. Campaigns to improve Canadian dietary patterns dated back to certainly at least the early years of the 20th century, but they really intensified during World War II. As Ian Mosby has addressed in his book, Food Will Win the War, there was a desire not just to save food for export to Europe, but also a desire to increase the efficiency of the workforce here at home through better nutrition. Now, the organization we studied, the Health League of Canada, jumped on board this campaign, berating Canadians for eating poorly out of choice rather than out of necessity. A 1941 League pamphlet, Eat Correctly for Health and Victory, claimed that in other countries, malnutrition was the result of food shortages, but that in Canada, it comes most often from an unwise choice of foods. In the years after the war, the League continued to scold Canadians for eating poorly, but also took up the cause of obesity, believing it to be solely the result of overconsumption. One article in their journal Health focused on a fat man who was clearly seen to be an object of derision and a laughingstock, and the language, quote, "To consider yourself big-boned, pleasingly plump, stylishly stout, chubby, well-rounded, or just of heavier build is pure fancy. If you are 10% heavier than your ideal weight, you are obese." And warned that 2 million overweight Canadians would be ill more often and die earlier than other Canadians. There was a real lack of sympathy for Canadians who found it difficult to control their eating in an increasingly commercialized food landscape, which provided more options for snacking and convenience than ever before. And the judgmental language here is quite similar to the Lalonde Report preface, which condemned those eating patterns which put the pleasing of the senses above the needs of the human body. Exercising more. The Canadian Social Hygiene Council, the predecessor of the Health League, received large grants from the federal government for its health education work in the 20s, and they regularly circulated this pamphlet, Healthy, Happy Womanhood, which advised women that physical fitness during youth is the best foundation for a healthy, happy womanhood. It urged women to swim, skate, canoe, and play games. In keeping with the eugenic principles of the day, it suggested that young women find a physically fit spouse to give their children a clean bill of health. The National Physical Fitness Act, passed during World War II for some of the same reasons as we saw nutrition campaigns during World War II, was intended to promote physical education in schools, universities, and other institutions, including workplaces. It established a National Council on Physical Fitness and established a National Physical Fitness Fund. And as Catherine Gidney has shown, in the post-war period, many universities required students to take physical education, which included activities such as swimming, badminton, and dance. Upon his installation as the president of the Canadian Medical Association in 1959, the Duke of Edinburgh famously castigated Canadians for their lack of fitness. The Duke's speech, along with Canada's embarrassing performance in the Olympic Games of the 1950s, sparked the Diefenbaker government to pass the Fitness and Amateur Sport Act in 1961. And in the early 1960s, Health devoted an issue a year to physical fitness, urging Canadians to skate, canoe, ski, and golf, sports commonly undertaken by middle and upper class Canadians who could afford ski trips and country club fees. They did also include recommendations to do calisthenics, walk, and do rhythmic gymnastics, so slightly less expensive ones as well. But you can see this emphasis on physical fitness far precedes the Lalonde Report. And actually, we were talking about the Healthy Swede earlier today. I mean, that actually comes out in '73 before the Lalonde Report is published. Drinking less. So Canada, of course, had a robust temperance movement, and a wide array of moral reformers had encouraged Canadians to drink less since before Confederation. This culminated on a brief national ban on alcohol sales during World War I, along with some longer-lived provincial and local bans. Before World War I, moral reformers regarded alcohol as a moral and health danger for all those who consumed, with a focus, of course, on the heaviest consumers. But with the repeal of prohibition in most provinces in the 1920s, physicians began promoting the idea that alcohol was only dangerous for the so-called alcoholic. There was a recognition that alcohol could be dangerous in certain circumstances, even for social or casual drinkers. This was especially true of driving. After all, prohibition was repealed just when the car was taking over from the horse as the major form of transportation for many Canadians. One of the first international conferences on alcohol and traffic safety took place in Toronto in 1953. And you see all this in Health magazine too. It warned Canadians of the dangers of alcoholism and urged them to avoid alcohol if they felt that their use was becoming problematic. And you can see here again the emphasis on personal responsibility, the overdrinker's responsibility. They also urged Canadians, in addition to abstaining from drinking and driving, to also abstain from water-based activities. And they also included lots of warnings about the overuse of other kinds of substances as well. So regular warnings against barbiturate and tranquilizer use. Also, interestingly, condemnations of the overuse of antibiotics and laxatives as well. So the Lalonde Report drew on a well-established tradition of victim blaming in the field of public health. The health field concept definitely did allow for a broader thinking about the conditions that created health. But the concept of the social determinants of health really came out of the UK and Europe, not out of Canada. In 1980, the Black Report, written for the UK government, provided a scathing account of the impact of inequality on health and argued that these gaps had actually been increasing rather than decreasing since the establishment of the National Health Service in 1948. Now, the Black Report, not surprisingly for Britain, was very, very focused on social class at this time as opposed to other types of inequality. The Thatcher government, not surprisingly, buried the report, but this reaction, Virginia Barrage explains, actually gave the Black Report a certain cachet in leftist circles, helping to encourage the growth of research in this area. The Black Report was then taken up by the European region of the World Health Organization, which agreed to a common health strategy with equity at its heart in 1985. And this is the Targets for Health for All report in 1985. And it's just 9 years after the Lalonde Report, but if you read them side by side, the difference is huge. The attention to structural factors is very, very strong in the Targets for Health for All, which is not there in the Lalonde Report. By the time of the 1986 Ottawa Charter on Health Promotion, which emerged out of an international conference organized by the World Health Organization, Health and Welfare Canada, and the Canadian Public Health Association, inequality was front and center, although I note that it still doesn't appear on the front graphic of the report. In the UK, the 1988 Atchison Report drew attention to ethnicity as a factor in health inequality, although it's really, I would argue, only relatively recently that racism has been brought to the fore as an important social determinant. Thanks to the work of the World Health Organization's Commission on the Social Determinants of Health, chaired by Sir Michael Marmot, and Marmot's 2010 report, Fair Society, Healthy Lives, for the British government, I think it is generally accepted in health circles that the social determinants of health are vital to understanding health more broadly. In Canada, I think we've seen this most meaningfully in the response to the COVID-19 pandemic, where it was recognized very early that the pandemic would not affect everyone equally, and that there was a vital need to reach out in creative ways to traditionally underserved communities. The public health community also fought hard for economic supports like paid sick days to combat the pandemic. While governments certainly did not always agree on the necessity of these measures, especially in Ontario, where I am coming from today, they were at least widely recognized in the public health community. And I would argue that this sea change that we're beginning to see, and hopefully we will see more of, can really only be linked in the loosest of ways to the Lalonde Report, even if the report did put us on a new path towards understanding what makes for a healthy population. So I'll end there.
Well, thank you so much, Catherine, for this stimulating talk. We switch from a social to a moral vision. Thank you for enlarging our vision du rapport Lalonde. Cette interprétation-là, elle est importante, alors merci de l'apporter. Our third speaker and our final speaker for our round table this morning is Professor Marchildon. Gregory P. Marchildon is Professor Emeritus at the University of Toronto and the founding director of the North American Observatory on Health Systems and Policies. He has written extensively on comparative health systems and the history of Canadian Medicare. His most recent book, TC Tommy Douglas and the Quest for Medicare in Canada in the 20th Century, will be published in the coming month. And the title of his presentation is Lalonde and the Fiscal Politics of Canadian Medicare. Professor Marchildon, it's all yours.
Thank you very much for the invitation. I was about to say now for something completely different because the term Medicare is generally not put in the context of the Lalonde Report except in a negative comparative way, and I'm going to talk about them as being on a fairly continuous policy cycle. And so this is an attempt to, in a sense, set not only the context of the time, but to talk a little bit about the present and the future at the very end in terms of what we can draw from the Lalonde Report. So why did I bother doing this research and create a paper out of it? Well, the first is I really wanted to get at what was the change agenda in the government of Pierre Trudeau at the time, its reorientation of the Canadian Federation, especially fiscal federalism, and to better understand the elimination of what had been the dominant policy in Medicare and in other areas of the welfare state, that is shared cost program financing, why that change occurred, and the desire to shift resources, federal resources, from Medicare to investments in health promotion and illness prevention, and how the Lalonde Report provided a conceptual rationale to reset federal priorities. So I will start with what was the spur to all of this, and the spur to all of this was right here in the province of Quebec. And at the time of the 1960s, particularly the mid-1960s, the Pearson government's response to the Quiet Revolution and growing action by the Quebec government to take control of social policy areas and to change shared cost programming. The Premier, Jean Lesage, who you can see in the picture here, and his cabinet, including René Lévesque, said that while the Quebec government would accept universal hospital care in 1960 and implement it, that would be the very last shared cost social policy program that the Quebec government would ever accept. And the Pearson government responded to that through accommodation. You saw that through, for example, the creation of the Quebec Pension Plan, Canada Pension Plan arrangement, and the allowance of opting out of this fiscal financing by any province at the time, although it was really tailored to Quebec's requirements. and the notice by Quebec in the mid-1960s that in fact it would opt out of universal hospital care financing, and it would accept a tax transfer in its replacement, and it would be in charge of that program fully as of 1970. That was given a 5-year notice. The Trudeau government, when it was elected in 1968, decided to take a very different position. And one of the things that it did was it basically said, we are going to eliminate unilateral tax transfers to Quebec alone. There will no longer be these bilateral arrangements. It will be an arrangement that will be for everyone or for no one. And the person that was really critical in this was Marc Lalonde, and he was the principal secretary in the Prime Minister's office to the Prime Minister, and he was really his Quebec lieutenant and the mastermind of the strategy and the reorientation to federalism and to Quebec's demands. He fought on 2 fronts. I'm not going to go into the first front, but he was heavily involved in dealing with the separatist movement, the War Measures Act, etc. But the second front was to reverse the trend to asymmetrical federalism by adopting a more focused and narrow federal policy and program agenda, and resurrecting the idea that had been dropped in the Pearson government of a permanent tax transfer for social programs for the provinces. This had to be an all or nothing program. It was kicked off with the First Ministers' Conference in '71. By that time, Lalonde had decided that there were going to be other aspects to this, and Trudeau wanted him in the cabinet and asked him to run, and he ran here in Montreal, in Outremont, to become an elected member, and that's how he ended up becoming Minister of National Health and Welfare. And it was Lalonde's job to lead the negotiations on what we today call the block transfer, replacing shared cost financing. And it was in part to control federal expenditures, and everyone knows that. But what is less known, it was really part of the federal effort to move to a more symmetrical federalism. This absorbed considerable time, I would say much of Lalonde's time during his period as Minister of National Health and Welfare between 1972 and 1977. And the negotiations on this arrangement predated the Lalonde Report, ran alongside the Lalonde Report, and then carried on after the Lalonde Report because it took until 1976 to reach an arrangement with the provinces. It wasn't what the Trudeau government fully wanted. It was a compromise. It became, the block transfer became half tax transfer and half cash transfer. But they said that was better than nothing, and they got all the provinces to sign on. Of course, while all of this was taking place, what became known as the Lalonde Report was being developed. This was being done within what was called the Long Range Health Planning Branch within National Health and Welfare, which had been established in 1971 and was really the policy think tank for the department. Hubert Laframboise, who's already been mentioned, actually wrote that first draft. But I'm going to mention another person who is not remembered anymore. His name was Raymond Lechaine. And he was a person that had been seconded from another part of the federal government into National Health and Welfare to work on federal-provincial relations. But he also was the most important editor of the actual think tank piece on the health field concept that came out in 1972 in the summer by once this came out, it was subject to editorial review within the department, and they decided to migrate it from basically a think piece by Laframboise within the department to a governmental green paper. And this occurred in 1973. In January of that year, Lalonde was busy dealing with the new tax transfer proposal in meetings with ministers of finance and ministers of health. But he got Laframboise to publish his health field concept in the Canadian Medical Association Journal to disseminate the idea. And that was done in February 1973. And Lechen had worked on this and convinced Laframboise to replace the field of technology, which he originally had, with what was called human biology. So it was a pretty important change in terms of the four health fields. And contrary to what Laframboise said later about there not being any consultation, it then went through very extensive consultation with the provincial deputy ministers of health in 1973. There were 3 meetings of those deputy ministers, and they reviewed the health field concept very extensively. And to keep in mind that they were both influenced by it, but it was something that was already in the air and something that they had been working on themselves in terms of reorienting provincial policies and programs in healthcare. And then Lalonde himself presented first in Geneva, then in Ottawa, in terms of the Pan American Health Organization. And in that discussion, it was clear that lifestyle, from Lalonde's perspective, was the critical part of the report. And Catherine's already talked about that, but that definitely came out in that speech in Tupaho in 1973. And we've already discussed the influence of Thomas McEwen. That too came out right at the very beginning of his speech. The Lalonde Report comes out in 1974, but what is not as well known is the cabinet pushback that occurred. It could have come out early that year, but there were at least 3 ministers that were very concerned about aspects of the report, but the most important of these was the Minister of Finance, John Turner, who felt that the report really was dangerous in setting up expectations for new funding in these areas of population health and health promotion, illness prevention, and had very extensive revisions done to the report to lower expectations in terms of new funding, because this was supposed to be also part of the federal government's efforts to reduce its federal risk and its expenditures in terms of the provinces in transfer grants. So it took a little while, but the report was finally completed in April, and then in May, on the 1st of May, it was released in the House of Commons. The opposition poked fun at what they called the motherhood nature of the report. And there was a demand for even more concrete recommendations from the NDP and others. In contrast, the response to the report within intergovernmental fora among provincial ministers and deputy ministers of health was much more positive. In a sense, they were ready for the report because they had been heavily consulted the year before. And they set up a committee, a federal provincial committee, to pursue implementable programs. But this agenda became somewhat hijacked by the continuing discussions concerning a tax transfer, which would become known as Established Programs Financing, EPF. This programming, or this new established program financing agenda was to allow provincial governments all the flexibility that they needed to apply transfer money to any health area, including illness prevention and health promotion. Now, the EPF negotiations would go on for another couple of years, but what's interesting, and I looked at the Canadian Medical Hall of Fame's awards to both Lalonde and the Deputy Minister of National Health and Welfare, Maurice Leclerc, is that in Lalonde's case, there is absolutely no mention of the tax transfer, and he was given the award completely for the work on the report itself. And what's strange about this is I would think that he spent about the vast majority of his time trying to achieve that new fiscal agenda, and a very small portion of his time on the Lalonde Report, and yet it was the Lalonde Report that was very much being lauded in terms of the achievement. And the other part of that is that, of course, the fact that it became a Lalonde report, a government report, meant that he was recognized along with his deputy minister, but not the person that actually wrote the first draft of the report or the other people that wrote the report. But that's just the nature of how government works, of course. Now, comparing impacts, and I want to basically end on this and compare side by side the block transfer and the Lalonde report. In the short term, the block transfer really made an enormous change in terms of relaxing federal monitoring and conditionality. And the immediate impact of that was to lead to a rapid growth in extra billing and user charges for Medicare in the provinces. And this in turn led to the Canada Health Act. And the interesting aspect of Monique Bégin's book that was published in 2019 is she says very clearly she did not understand as a cabinet member what the EPF changes were when they came into cabinet and the discussion around the cabinet table, and she discovered after that virtually none of her colleagues understood it at all. And she asked Marc Lalonde about it when she became minister again, reappointed in 1980, and he said, "Don't worry, this doesn't change anything." And she quickly discovered, of course, that it changed a great deal. And it was what the second Hall report also said, was that it changed a great deal, and there needed to be legislation that would, in fact, alter this. And it did through the provisions on extra billing and user fees. But that's all that it dealt with. It was largely restricted to that, something which Madame Bégin fully admits. In terms of the long-term change, is it permanently reshaped federal-provincial relationship overall and in social policy quite fundamentally. And it's the reason that we have this endless provincial demand for more federal cash. When you had shared cost financing, that was not an issue. The federal government shared half of provincial costs, so you knew every year generally what you were going to get. There was no issue there. But that changed to a situation where you not only were demanding more cash, but you were demanding that the escalator be changed. And health became the demand for all money in the transfer. It didn't matter if it was intended for other social purposes, post-secondary education. You know, as a provincial premier and finance minister, that the public has more sympathy for your demands for health than for other things, so you basically put it under that column. When it's really an argument more about money and the conditions upon which money arrives than it is about health. The Lalonde report, the short-term impact was quite limited, in part because everything got derailed through the EPF arrangements. And so they couldn't work as much and in a focused a way on figuring out how to implement the recommendations of the Lalonde Report. And these recommendations were largely in the hands of provincial and local governments anyway. And the provincial governments were basically on their own trajectory. So what this did was this basically did not allow for the real opportunity for what I would call interprovincial work across provinces. More importantly, it did not fundamentally reshape, except at the margins, the federal government's direction and priorities. And that's a more complicated story, which I can't go into here, but I think it's in part because you ended up with a half tax and half cash transfer, so the federal government was half in and half out of Medicare from that point on, but it could not, in a sense, focus as heavily as it wanted to in what it considered to be these more urgent areas. And one of the things that was really important in the Lalonde speech in 1973 was his acceptance of the argument that there was decreasing returns on investment to medical and hospital care. That was clearly evident, and that the smarter thing to do is to invest in areas where there would be increasing returns on your investment. And that was in the areas that were been identified: lifestyle, human biology, environment, etc. The more hidden thing, and you may disagree with me on this, but I think the report had some influence on provincial reform agendas, in part because it was already in the policy air in the provinces. Ministries of health at that time were much more powerful in terms of their policy and planning than today, and they were thinking about these things very deeply. And so you had a community health center movement in the 1970s. The ideas of regionalization that existed at that time, which weren't implemented really until the 1990s, but the ideas were already there, were basically for joined up program and policies that would, in fact, combine health and healthcare. And the shift from illness to wellness, which again did not occur in a major way until regionalization was adopted in the 1990s. So continuing challenges, questions concerning both established program financings and the Lalonde Report. While there continues to be a tension in the allocation of public resources, the medical versus the non-medical determinants of health, some see this as a trade-off. There is always the continuing question of the role of the federal government in terms of health care. Should it be Medicare and non-Medicare? And what should it actually do in promoting, preserving, and enhancing health? What is its role? Does it have a role? The next is the impact of federal health financing through block transfers. The mechanism itself, the quantum, and the issue of escalation. The next is the method of determining whether extra flexibility that was provided through established program financing actually encouraged greater relative investment in health versus healthcare. We still don't know the answer to that question. And finally, whether flexibility through this new block transfer mechanism has simply led to less effective and less enforceable national standards, the 5 criteria of the Canada Health Act, or whether it has led to a more balanced provincial approach to health and to health care. I would say that I'd just like to quickly end on the I was going to say the Batman and Robin of Canadian politics of the 70s, but that analogy is not a great one because the person that was viewed as the Dark Knight at the time was actually Marc Lalonde, the enforcer. So I want to thank you very much for your patience, and I look forward to your questions.
Thank you, Professor Marchildon, for this wonderful perspective on a federalist perspective and incorporating this within the Canadian federation system. So thank you so much. I think we have three wonderful perspectives that were brought to you this morning, et merci vraiment beaucoup d'avoir apporté ces dimensions. Je pense que le moment est venu pour vous d'avoir l'occasion de partager vos questions, vos observations avec nos trois intervenants et intervenantes. Donc, je vous invite bien sûr à poser vos questions. If you would like to ask your question, please do so by we would invite you to simply identify yourself, please, and ask your question directly to one of our true speakers. We do have a virtual question, and I may start with that virtual question. So the question is from Eric Breton. And the question is the following. So I have this feeling that the work underpinning the Lalonde Report, which was issued by the government of the Liberal Party, was first grounded in a concern for the rising share of health expenses in the GDP of the country. In other words, it is some kind of Ministry of Finance report disguised as a Health Canada one. What are the speakers' view on this? Anyone would like to tackle this or to answer that observation? Professor Marchildon?
I guess I raised that issue, so I'll try to answer it quickly first. It's much more than that. It was part of that agenda, but Laframboise, the original author, and the people that worked on it after with him really had other purposes in mind. They weren't simply trying to serve that purpose. And I want to return to the issue of the idea of returns on investment and the idea of decreasing returns. They accepted that, but they also said that Medicare needed to continue, and that you just simply, it wasn't a matter that one was a replacement for the other, but that additional federal investment should increasingly emphasize the other areas.
Yeah, I'd just like to make one. I agree totally. Certainly money, is this working?
Yes, it is working.
Money is certainly one of the issues. Cost effectiveness is mentioned. But behavior change has gotten a very, very bad rap. And you need to go back to the 60s and 70s when works on the role of smoking and the role of exercise were taken up by a lot of people of the left. They were people seemed very, very surprised that Jerry Morris, who was a man of the left, got so excited about this. The same thing is true in the United States. Most of the public health figures who are talking about this sort of thing consider themselves men of the left. But it was so dramatic. Here was real data. I mean, in order to imagine that poverty was a major factor in illness, you didn't have it. It made sense. It was plausible, but the data was indirect. The data was indirect, where greater illness among poor people seemed correlated with certain things. Here was something that was simple. It was low-hanging fruit. You didn't have to transform the political system, and yet it seemed to have very, very dramatic changes. And it's true, by the 1980s and in the UK, there was a reaction to it. In many places, there was a reaction to it as being a very narrow way of thinking about it. But in the 60s and 70s, this was really big. I mean, it was really exciting stuff. And people, you know, I think we've lost our sense of that.
I'll maybe add to that too. I mean, I agree that it was about more than saving money, absolutely. And there was this very important recognition that health needed to be about more than just providing people with hospital and physician services. On the sort of lifestyle pieces, I agree that absolutely the evidence showed, you know, very dramatic impacts from smoking, for example. So it was an easy thing to focus on. I just wish that it had been done in a less judgmental way with more attention to the structural factors that determine, you know, the nature of the kinds of lifestyle habits that people are able to assume. And although that is there in other places at the time, it is, I would argue that it's not particularly there in the Lalonde Report.
Thank you for that. Question from the room? Yes, please.
Hi. Okay, so thank you for your presentations. So my name is Michael and I'm a student at McGill. I guess my question is a little bit about related to the theme of the whole conference. And it's more of a maybe like philosophical question about the burden of responsibility. So when it comes to health outcomes, how should we determine whether those outcomes fall under the responsibility of the individuals, and when does it fall under the responsibility of the government and policy making?
Merci. Merci beaucoup, Michel, de la question. We were lacking a philosophical perspective, so thank you for that question.
Maybe I'll tackle that one first because it's most
Catherine.
directly in my area.
Thank you.
I mean, I think certainly there is a role for government in terms of informing people about healthy lifestyle choices. But at the same time, I mean, a lot of these things aren't choices at all, right? They're determined by the jobs we have, the housing that we live in, our experience of daily racism, our lack of experience of daily racism. So again, I think we always need to take it back to those larger structural factors that impact people's lives.
Wonderful. Thank you so much, Catherine, for that answer. We have a question as well from one of our virtual attendees, and it is from Joseph Brezhnev. And the question is the following in French. Comment les politiques publiques peuvent-elles être réorientées pour intégrer de manière plus holistique les déterminants sociaux de la santé au-delà des éléments conventionnellement ciblés comme l'alimentation, le tabagisme et l'activité physique, comme identifié d'ailleurs dans le cadre du rapport Lalonde. De plus, pour les 2 décennies à venir, où observez-vous une prise de conscience accrue et une intégration plus globale des déterminants sociaux de la santé dans les politiques publiques? Anyone that would like to offer a piece of reflection or answer to that question?
I mean, sorry, I'll jump in again, but I think one of the things, if we looked at public health, and public health took as its first sort of raison d'etre solving homelessness, as opposed to sort of educating people on lifestyle, what would the impact of that be on people's health outcomes? but also, how could we sort of totally reorientate and reshape public health so it's not focused on those sort of lifestyle sort of promotion pieces.
Thank you for that. Any question in the room? David, please.
I don't know whether I'm allowed to ask a question. Is this on? Oh, this is on. Okay.
I think the other one was working, David.
The other one was on?
Yep, it was.
Feel like a rock star. I'm seeing it. So, excuse me. I just want to ask if you want to comment further about the role or situation of the elderly in the Lalonde Report, right? Because it really is quite striking. You reread the Lalonde Report and say, okay, everyone under the age of 5, we sort of dealt with that, okay? Been there, done that, solved that problem, okay, dramatic decline in infant and childhood mortality. And, oh yeah, everyone over the age of 70, well, they're really not our concern, right? And like, it more or less says that. And I'm just, I'm sort of thinking about the emergence of gerontology as a subdiscipline in medicine. And so I'm wondering if any of you want to talk a bit further whether, Greg, there was policy discussions going on in the back that decided, no, we're going to not discuss care of the elderly, or what have you. But I wondered, and George, vis-a-vis the chronic care hospitals and the like. So I didn't know whether any of you want to say any more about the 70+ group who still represented a significant proportion of Canadian and North American society.
Thank you, David.
I tried to make in my book is that a lot depended on whether chronic disease was seen as a problem of old age or not. And in France and Britain, in the UK, it was very much seen as a problem of the elderly, which meant that it wasn't really taken very seriously. One of the things that reformers in the United States were able to do is they were able to claim, and they were taken seriously, that it wasn't just a problem of age, that many, many young people, in fact, had chronic conditions. And that made it a lot easier to institute the kinds of changes they were trying to make. There seems to be no question that, and I think the baby boom generation has made a huge difference about this. I think we now take aging a lot more seriously than we used to. But the problem of aging was largely a welfare issue rather than a medical issue in many, particularly the disabled elderly. And I think that's one of the great differences, both between countries and chronologically between different periods of history.
This is only a partial answer, but I did see in the work of at least one provincial Department of Health, and it wasn't viewed as a welfare issue, it was viewed as a health issue, and it was seen through the prism of long-term care. Major piece of work that was done in the late 1950s and early 1960s, largely done in Saskatchewan, but involving other departments of health in the country, where they really began to examine long-term care. And I don't know what happened in other provinces after that, but I've seen references to some long-term care planning in other provinces, and in a way that was not being adopted in national health and welfare. So that's where the responsibility lay anyway, was with the provinces, and they were trying to make this part of the sort of a, I won't call it seamless, but part of a health system in which they saw governments, of course not hard for a social democratic government in Saskatchewan to see it as a public responsibility, but there were other governments that saw it that way too. that this was indeed a public responsibility. And so I think that that is something that has not been addressed by scholars, and it would be interesting to see it addressed.
Yeah, I'll add to that too, David, because I'm so glad that you raised it. We desperately need more, and I'm someone who rarely says we desperately need more histories of X, Y, and Z, but we really need a history of aging in Canada. We have some work for like earlier 20th century, mostly pre-1950, but the fundamental differences we've seen both in terms of people's lifespan experience and their lives as they get older really needs to be studied in more depth. And yet at the same time, even though our expectations about life expectancy have changed, sorry, that's a very badly worded sentence, enormously, I still think we have that sense of deaths over a certain age matter significantly less, right? And we saw this, actually one of the slides that Carolyn Bennett put up, which I thought was so fascinating, was the 44 deaths in 2003 from SARS in Canada compared to the 14,000 deaths from the heat wave in France that summer. And I have to admit, I had even forgotten that France had had a heat wave that summer. And we know from heat waves that, again, it tends to be the older populations that die of that. And so, we still see, and I think, part of the huge public protests we saw against COVID restrictions in Canada was really about, well, it's only old people who are dying, right? So, that legacy is unfortunately, I think, still very much with us, even though other aspects of aging have changed enormously.
Thank you. We have time for one final question. Yes, please.
Thank you. I think this one's working better. This is not a good end of session question, but what do the panelists think about the impact of EPF on the federal government ever having an agenda that responds to the big concerns of people who do not seem to get interested in defense policy or foreign policy, but as Greg said, even at the provincial level, it's hard to get them interested in post-secondary education when health dominates. We've had EPF now for some time, and what do panelists think? Did the federal government take itself right off an agenda that Canadians care about?
Thank you for your question.
Yeah, actually, that's a multi-layered question because I think about the negative legacy of EPF, and most negative legacy has nothing to do with health, has everything to do with the toxic federal-provincial relationship, which comes from, governments constantly demanding money where another government taxes for it, and that is because of this half-compromise arrangement. But looking to the future, you can see another type of government coming in and saying, we're going to do a permanent tax transfer and we're out of this completely. And that's been put on the agenda before. And I think that would go contrary to and be counter to what many Canadians would want to see. And the thing that confuses Canadians who are watching this, every time there's this debate about health funding, they think it's about health care. Mm-hmm. And they're hoping that the solution, every time there is a final agreement through a federal provincial process, will be a solution for health, but has nothing to do with it. And so it is both confusing and frustrating for the general public, I think. And it's actually a very, it's actually a real problem of accountability as well. And I think that we're really going to have to get back to the drawing board to get this fixed if this country is going to make progress, because it has created a real paralysis in terms of both healthcare policy and health policy writ large.
Any final thoughts or comments on this? Or it's fine. Great. Well, we'll end up on these wonderful words. Let me thank you on your behalf and thanking George Weisz on this wonderful presentation, Catherine Carstairs, and as well Gregory Marchildon for 3 wonderful and stimulating presentations. Thank you so much for this. We will take a lunch break for 1 hour, and please do come back as there's a stimulating panel coming at 2 o'clock, implementing the Lalonde Report. Merci beaucoup. Bon lunch et à 2 heures.
Et en remerciement à nos panélistes et à notre modérateur.